Hi, my name is Fernando Martinez, and welcome to our program today. You see the title there, Strategies to Reduce Morbidity and Mortality in COPD, a patient-focused approach. I'm the Chief of Pulmonary and Critical Care Medicine in Weill Cornell Medicine in New York City, and I'm here with my colleague, MeiLan.
Hi, Fernando. Good to join you.
Hello again, MeiLan. It's the third time we've talked today. You'll see in the next slide that we have a series of disclosures, some of which are relevant because some of the agents that are made by some of these groups are actually points that we'll discuss today. And we'll point those out as we go across. There are a series of learning objectives that we want to make sure that we cover, and those include describing the updated criteria for diagnosis of COPD for early recognition, assessment, and so on. We want to review some of the updated guidelines and therapeutic strategy recommendations for the use of combination bronchodilators in patients with COPD. And we also want to identify some of the strategies like pulmonary rehab and then the evolving data regarding triple inhaled therapy combinations for specific patient subsets to particularly address morbidity and mortality.
So if you haven't done so already, please complete the pretest. You can find it at integrityce.com/COPD pretest 1. You can also find the link in the description of this video. So in the interest of time and covering this content thoroughly, we've pre-recorded the didactic portion of this program, which is going to play now. But we will be back at the end for a live question and answer session. You can post or tweet any questions throughout the duration of this program in the comments below, and we really look forward to answering your questions. So without further ado, we're going to dive right into the presentation to talk about COPD burden and unmet needs. It's just jumping right in, as you can see on the map that we've got up here, which shows the prevalence of COPD in the United States. You can see that where I'm at in Michigan is one of the most prevalent states. There's really a significant amount of variability. We know that COPD is more common in rural areas. And unfortunately, these are also the patients that have the greatest barriers to care because of where they live. So I think it's just important, find yourself on the map, but it helps to understand where much of the COPD in the US is. So from a sort of a healthcare perspective, I also think it's important to realize just what a huge burden on the healthcare system caring for COPD is. In prior assessments, attributable costs for COPD were around 30 billion, projected to be 49 billion. And it's not just direct care for COPD, it's also the hospitalizations, it's the work that those individuals are not able to do, it's the work lost by caregivers. So there's quite a few both direct and indirect costs that are associated with COPD. So it's definitely something that I think many we as providers, but also many healthcare systems are starting to pay more attention to try to figure out how can we overall drive down costs for COPD care. Now, one of the things that has also been really challenging for me as a provider, and I'm sure many of you have seen this in your own practices, is that COPD is often diagnosed quite late. I had a gentleman a few years ago come into my office. He said, yeah, I was noticing I was a bit more short of breath. He finally got some pulmonary function testing, was referred to my office. And to be frank, at that point, his lung function was at the level that I would be considering him for a lung transplant, believe it or not. And this was the first time he'd ever had pulmonary function, the first time he'd ever seen a pulmonologist. So unfortunately, those kinds of stories are really all too common. A study from 2010 found a high prevalence of previously undiagnosed COPD patients presenting to the hospital for the first time with an acute exacerbation. So it really is not uncommon for the first time a patient to really come to the awareness of the healthcare system to actually be a hospitalization for the event. So this, I think, it's important to realize that we've just got a lot of patients out there, and as a community, we really need to be thinking more deeply about how we can try to find these patients and get them on appropriate therapies. So one of the challenges that we as pulmonologists have, though, is that the use of spirometry, while it's increasing, still remains, unfortunately, pretty low. So this slide shows spirometry use among older adults with COPD and how many of those had had spirometry sort of around the time of their initial diagnosis. As you can see, it's gotten a little better comparing 1999 to 2008, but we still have a lot of room to go, both in terms of, I think, underdiagnosis, and then sometimes we have misdiagnosis just because of the kind of mass underusage of spirometry in our healthcare system. Now, some of the factors that have been found to be associated with increased likelihood for spirometry include younger age, male sex, white race, higher socioeconomic status, and higher number of comorbidities. Unfortunately, we also know COPD is also a disease of women, and also not all patients have equal access to care. So that's where that socioeconomic impact weighs on me personally. COPD, these are healthcare disparities as well. So I think as a system need to figure out how to take better care of these patients. So Fernando, I'm going to turn it over to you to talk more about this.
This is a paper which I'm the first author, MeiLan's a senior author. So we were both involved in this particular project. And it was actually an interesting project. It took place about a year and a half ago. So this must have been 2019 or before the pandemic began. And we, as part of a QA program, were we approached a series of pulmonary and primary care physicians at a series of healthcare centers in a healthcare system in the southeast of the United States. And we had a survey that we asked the clinicians, do you do this or this or this? What do you think your patients would say to this or this or this? And then we asked them, and also, by the way, can you allow us to contact some of your patients? And we're going to ask them the same thing. So what's seen on this slide on the left-hand side is a sample of the questions we asked the providers, and on the right-hand side are the questions we asked their patients. So when we look at the very top and we ask the clinicians, do you use one of these standardized or validated instruments? MeiLan and I will talk about more later on. Did you use them most of the time? Rarely. You can see what the clinicians thought, particularly the primary care versus the pulmonary clinicians. And then on the right-hand side, we asked the patients a little bit differently. Does your doctor actually ask you whether you have cough or sputum? And you can see some of the discrepancies that are seen there. To me, one of the more interesting components are subsequently. So MeiLan, the diagnostic use of spirometry in this particular health system was actually higher than the last set of data that you presented for 2008, which is a good thing. But look at some of the other components. I thought this was particularly important, this third major bullet. What percent of your patients do you think have at least 2 exacerbations in the last year? That becomes relevant when we talk about some of the gold therapeutic strategy recommendations. And the clinician said, oh, about a third of them. And then you ask their actual patients, so how often are you having these flare-ups? More than twice a year. More than half of them did. So there's a huge discrepancy between what a clinician thinks is happening to their patients and what's actually happening to their patients. And then the last one is when we ask the patients, so why do you think your patients aren't taking their medications? And the clinicians thought, oh, it's the medication cost, and they don't think it really works. And you ask the patients and they say, oh, I just forgot to take it. And so it's interesting because it highlights some of the challenges that MeiLan and I will discuss in terms of therapeutic approaches to patients when we talk about complex polypharmacy and multiple therapeutic modalities. So this is sort of a real world assessment of what clinicians, at least this snapshot of clinicians and their patients think. So MeiLan, as I'm thinking about this sort of an introductory component that what you and I have just provided, if you had to say what you thought was the most important unmet need for patients in COPD, what would you say that would be?
That's a really great question. I think we have so many unmet needs. So we've just been talking about just the fact that we have a lot of patients that are not appropriately diagnosed, aren't getting spirometry. Sometimes clinicians are unsure about how to do spirometry, and that's really important both for not just diagnosis, but disease staging. But then we've got all these other things like that you were just touching on, that we have inadequate communication between providers and patients and education with what an exacerbation is. The fact that we have medications that can be used to prevent them. You need to call when you are having these kinds of events. And then, with the pandemic, I'm curious about with your patients in New York, Fernando, but one of the biggest problems I've had is patients don't want to come in and they're not getting exercise and they're not doing pulmonary rehab. So just a lot of new challenges. We had prior challenges, but just even more challenges with the pandemic in the last year.
Yeah, no, I mean, there's no question. You can't talk about anything in pulmonary now without talking about the pandemic. When we're recording this presentation, MeiLan and Michigan are in the tail end of their next wave, their
Surge
most recent
3.
wave. Yeah, and in New York, we've had this long taper of this last wave, and so every challenge that we had previously that you pointed out has been exacerbated in the setting of the pandemic. And as we talk about some of the components of evaluation and therapy over the course of the next couple of sections, we'll highlight to you where the pandemic has had some of these effects. There are some good things that have occurred with the pandemic, so there are less otherwise viral exacerbations. But most of the stuff has been really a challenge for our patients. And so, MeiLan, you highlighted already that one of the challenges has been this diagnostic approach. So can you take us through at least how you view the diagnostic process that we would encourage our colleagues and patients to undergo?
Sure. So on the slide that people can see, we have outlined what GOLD recommends to be considered when trying to determine whether a COPD diagnosis is warranted. And in full disclosure, both Fernando and I are on the GOLD Scientific Committee. So these are things that we've talked about and I think generally agree with. But these include things like shortness of breath. Is it reliably worse with exercise and then perhaps gets a little bit better with rest? That pattern, I think, can somewhat be helpful for identifying patients with COPD. A lot of patients also complain about chronic cough and sputum production. I think one of the challenges with all three of those things is that they are not uncommon in smokers, not uncommon as we age, not uncommon in patients who have gained, like many of us, gained some weight during the pandemic. And so patients have a tendency to blow them off. And so I think the onus is on us as care providers, not just to ask about the symptoms, but also to try to gauge activity and whether, they actually can, for instance, get through the grocery store without having to stop. Or how many times did you have to stop getting from your car in from the parking lot, into the office? These are the kinds of things that we really need to be talking to patients about. The next thing we have to look at is risk factors. So tobacco smoke, definitely a risk factor, but importantly, not the only risk factor. So there are other things like occupational exposures, just having worked in a job that was dusty or had, fumes can increase your risk for COPD. Factors within the home, being exposed to smoker or other factors, home cooking, heating, fuels, et cetera. So there's a lot of interesting data on this. Whenever I have a new patient with COPD, I always start with the beginning. I ask them about low birth weight, child respiratory infections. All of these things can set patients up for a lifetime of lung disease. And so these are all things that we really need to both, as a clinician, be aware of, but I think also get the message out to patients to try to get them to be more forthcoming and volunteer some of this information. So once we've identified a patient that has symptoms, has risk factors, spirometry is really the key to diagnosis. It's a key to diagnosis, and it's the key to staging. Now, ideally, that would be post-bronchodilator spirometry. So we look at a ratio of FEV1 to FEC and whether that's below a 0.7 to identify a patient who has airflow obstruction. And then we look at the GOLD stage at where that FEV1 is at to put patients into a disease severity classification. So mild or GOLD 1 is over 80, GOLD 2, 50 to 79, GOLD 3, 30 to 49, and with FEV1 less than 30% predicted would be GOLD 4. One of the interesting things that GOLD did a few years ago now was to separate spirometry staging from risk of symptoms and exacerbations. They're both important, both need to be thought about. I think about spirometry sort of like how far down the train track the patient is, and it's good to know that, to have those discussions. It may impact behaviors like willingness to quit smoking, things like that. Does the patient need to be considered for lung volume reduction surgery or valve therapy? But in terms of pharmacotherapy, we need to also be looking at symptoms and risk for exacerbation. And that's where the ABCD classification comes in. So patients with low symptoms based on MMRC or the COPD assessment test score, A and C are the low symptom groups, B and D are the high symptom groups. And then history of exacerbation, 0 to 1, or no hospitalized exacerbation, or A and B. And then the high risk have either 1 prior hospitalized or 2 moderate events in the past year, puts patients into C and D. So that's really, I think, how I I think it's a good rubric for putting patients into both a kind of a severity system, but also thinking about them with respect to therapy. Is that kind of how you approach your patients, Fernando?
Yeah, well, as you pointed out, MeiLan, you and I have both been involved in the generation of these recommendations. So I hope this is what we're doing. I think it's what we're doing. But I think that you've highlighted a couple of the components that remain quite relevant for all of us that are manage these patients, and that includes the fact that even in this most recent gold therapeutic strategy recommendation, spirometry is still considered to be the diagnostic test of choice, and the characterization of airflow obstruction severity in those categories remains an important point of determining when the patient is on the track and where they are on their track. I love that terminology. And there really are quite a bit of data that expand on some of the concepts MeiLan said earlier regarding the fact that spirometry remains underutilized. And there are a whole series of reasons for that, including practical difficulties in actually getting to a lung function lab, and for clinicians, particularly primary care clinicians, being able to feel comfortable in the performance of the maneuver and the interpretation of the maneuver. There was a study in 2018, which is referenced here, that only 56% of patients that had been diagnosed with COPD had ever had spirometry, not just in the last year, but ever. And in fact, when spirometry had been performed in 13% of the cases, it was actually concordant with their known disease. So this really still highlights the fact that spirometry not only is underused, MeiLan showed that earlier, but even when it's rarely used, it oftentimes is not used in the optimal fashion for ensuring a correct diagnosis. So there have been a sort of a series of attempts at deciding how can we minimize these particular difficulties and maximize an appropriate way to diagnose. Some of the data that are really quite not old, but are pre-existing data that try to provide a practical assessment of the likelihood of having obstructive lung disease without spirometry have been examined over the years. And this is one of my favorite quotes from one of those, which is that even if you take a smoking history and a previous history of respiratory disease, you listen to their lung, you see if you find abnormalities, or you even a physical exam, look for a prolonged expiratory time, that clinical impression is at most 80% sensitive. And it is sensitive for more severe disease. And so it is very difficult to be able to make a diagnosis, particularly earlier in the train track, that without spirometry. And so, MeiLan, this comes back to another question. Since you and I have both been big believers on spirometry and advocating for spirometry, what do you think is now the best way in the pandemic era and post-pandemic to try to enhance spirometric utilization in primary care?
Yeah, this is obviously a huge challenge. This is something that you and I have been working on for quite some time, and obviously doing spirometry is now even harder because of it generating aerosols. So I think, as you know, one of the things that you and I have been working on is a questionnaire. And I think there is potential. The one that Dr. Martinez and I have been working on is called Capture, but I think there is potential for things like questionnaires to bring patients to the attention of a primary care physician, and then they can either then do in-office spirometry or then move them over to the hospital. I actually think that sometimes there's this concern from primary care that unless I have a diagnosis, spirometry won't be paid for, or it's hard, or it's just difficult to get the patients in, or I don't feel comfortable interpreting the test. I think we have to say that's okay. Don't worry about that. Just screen, get the patients into our office, in the pulmonologist's office, or just start with whatever you can do. And if it's anything other than normal, then go ahead and move on. I would love to see a patient with normal spirometry. More than happy to see a patient with normal spirometry. And I think we've just got to lower the activation energy and the barriers. I don't know.
Yeah.
What are your thoughts, Fernando?
Well, I mean, you and I have spent years now working on this capture, and there are other groups around the globe that have developed similar combinations of simple questions and simple physiological testing that can be done in an office setting. And I do have a hope, MeiLan, that those will, at the very least, resonate with our primary care colleagues. As you know, you and I have worked very closely with a whole series of primary care clinicians in this capture validation And I'm hopeful that that type of approach will give a primary care clinician a bit more comfortable having a sense when they have to use a more advanced diagnostic method, something as simple as spirometry. And I do think that is going to become the future. And I think particularly so as we still recover from this respiratory pandemic, that those approaches may be even more relevant. But you brought up an important point there, which I think is one of the things that we've been trying to convince all of our colleagues in respiratory care and primary care, which is the diagnosis is appropriate to make because there are a whole series of COPD treatments that actually are effective in multiple ways to improve the quality of life and the function of our patients. So there are a whole series of interventions that we know are effective. For prevention and early intervention, smoking, vaping cessation, I mean, trust me, that has been demonstrated to improve lung function and survival. Vaccinations, and particularly now with SARS-CoV-2 vaccination in a high-risk population. The importance of regular exercise, MeiLan highlighted that on one of her earlier points. And then the concepts regarding pharmacotherapy. And one of the things that you and I have done as part of the Gold Science Committee is to be able to highlight to folks that if you use the schema that MeiLan highlighted earlier for stratification of risk for individual patients beyond just spirometry, this ABCD characterization, there is relevance to that because there is therapeutic relevance to that. And so in the GOLD therapeutic strategy, we specifically recommend for initial pharmacological treatment to utilize that assessment schema, which is why asking about the level of symptomatic limitation, the risk for exacerbation is so practical, because in some patients, it's just bronchodilators. And other patients is the introduction of combination therapy, and including the combination therapy with inhaled corticosteroids. So an appropriate not only diagnosis, but assessment of that patient is relevant with regards to multiple pharmacotherapeutic approaches that are actually effective. Not only that, but more recently, the GOLD Therapeutic Strategy Group, our GOLD Science Committee, extended this further to be able to say, we're going to give you not only some thoughts on how to initiate therapy, but how to modify therapy over time, and to use some of the more recently evolving data to help guide you in that respect. And that is what's led to this follow-up schema based on the treatable traits argument that Alvaro Agusti has been making. That for patients that have predominantly breathlessness, there are a series of incremental hierarchical interventions, long-acting bronchodilators, single and in combination, exercise, retraining the patients, ensuring they're using their devices appropriately. For exacerbations on the right, it's again, bronchodilators, inhaled steroids in combinations and increasing levels of combinations. And you see all these little asterisks that we've introduced into the schema. And those asterisks reflect the predictive value of eosinophil count, blood eosinophil counts on determining the likelihood of inhaled corticosteroid responsiveness. And we actually now provide some guidelines regarding how you could use those values to make individual recommendations for a given patient. I've become much more of a believer now in routinely using these eosinophil percentages, total numbers, to be able to guide specific therapy for individual patients. MeiLan, the GOLD is not the only group that you and I have worked with that has tried to develop evidence-based recommendations. You want to give a little hint to what the ATS has done?
So just recently, the ATS, instead of trying to do a massive comprehensive document that, addresses every single question we could possibly have, they really tried to focus in, and you and I participated in this, and kind of just asked some key experts, what are the big questions? What are the burning questions that if we kind of came out with and had a statement about, it would answer, it would help to guide the field, it would provide some guidance where there's some perhaps not so much clarity. And so some of the questions that they chose to address were, what's the appropriate starting therapy for patient with dyspnea and exercise intolerance? And where in GOLD we've got kind of this bronchodilator statement, ATS actually chose to come out and say, you know what, we think that the data is strong enough that should be a LABA-LAMA as opposed to either a LABA or a LAMA monobronchodilator therapy alone. So dual bronchodilators. Some of the other questions that they addressed were, when should we consider adding inhaled corticosteroids to LABA-LAMA combination? And It was felt that in particular, if the patient had had a severe exacerbation, that would be one place that would be appropriate to consider adding ICS to LABA/LAMA. When should we discontinue ICS? This is something new for GOLD, and it's something kind of new for the ATS to address as well. But felt that potentially ICS could be withdrawn, leaving patients on dual bronchodilator if the patient had not had an exacerbation in the prior year. And then they also came out with a statement, which I think everyone would agree on, that maintenance oral corticosteroids is really not appropriate for patients, even if they are having frequent exacerbations. So I think these, kind of additional caveats were kind of helpful to put into context with the GOLD document as well.
So MeiLan, realizing that you've been involved in both of these groups, where do you use monotherapy, if at all now, particularly just bronchodilator monotherapy?
I think it really depends on the patient. I definitely will give starting patients on dual bronchodilator therapy strong consideration. If, for instance, a patient has some contraindication to a LAMA, then, maybe I would consider one versus the other. Or another patient says they have severe heart racing with a LABA, they've tried it before. Okay, that's probably not the best patient. But unless there's, one of these contraindications, or for some reason I'm having a difficulty with insurance, but I would say more and more I'm leaning towards initial starts with dual bronchodilators. Has that been your approach, Fernando?
Yeah, that's been our approach. And I mean, I think you're going to present some of the data that's really influenced me in terms of the dual bronchodilator components.
So yeah, actually, let's dive into that. So in this particular study, patients were on dual bronchodilators, so umeclidine and philantrol, versus umeclidine in one of the studies versus salmeterol, a long-acting beta agonist in the other. And what you can essentially see is they looked at a couple of different things. They looked at breathlessness based on the TDI score. They looked at daily symptom burden using the ERS score. And then they also looked at rescue medication use and how many rescue-free days the patient had. And I think what you can see is pretty much across the board, the dual bronchodilator versus any of the mono therapies really did a better job in terms of improving breathlessness and reducing symptom burden overall. So a lot of my patients, the thing that they're honestly most concerned about is inhaled steroids, because they'd heard something about steroids, et cetera. I actually don't see a huge downside, though, to dual bronchodilator therapy. If you look at some of the safety data, there's really not that much difference. So there's not that much difference in the safety data, but on the efficacy side, you do get greater benefit in terms of symptom reduction with the dual bronchodilator therapy. So I think for many patients, it's a win-win, and there's not really a huge downside. I think one of the things that has gotten confusing for providers in the last year or two is the fact that we have so many more inhalers on the market in the United States than we did. And not only do we have different compounds, we have different types of devices and different delivery mechanisms. So, I won't go through every single medication here, but you can see that there are a variety of long-acting beta agonists that are now available alone, long-acting muscarinic antagonists that are available as monotherapy. And as you can see, we've got dry powdered inhalers, we've got soft mist devices, we've got nebulizers, and there is a lot of variability in what patients prefer, and to be honest, what they're most likely to use in an error-free way. And I will admit with my own patient population that sometimes it is a bit, you'll talk to them and try to understand what some of their barriers are. You have your nurse work with them and coach with them on the right inhaler. And there is, I would say, a little bit of this that is trial and error. When we look at the approved fixed dose combination therapies in the US, again, you will see more choices than what we had before. We now have LABA/LAMA choices, LABA ICS, and triple therapy. Now, we do not currently have any of those available in nebulized format, but we do have some soft mist. We've got metered dose inhaler, again, dry powdered inhaler. So we've got a lot more options now for patients than we used to. I think one of the things that we do need to, we talked about starting patients on dual bronchodilator therapy, but when it comes to initiating inhaled corticosteroids, I think this is where we really need to think a bit more. And I think there's good evidence that for patients that have had frequent exacerbations, a hospitalized exacerbation, maybe have concomitant asthma, or in particular high eosinophil levels, I think there's pretty strong support for using inhaled corticosteroids. I think where Gold says consider use, but maybe the data is a little bit less strong, is blood eosinophils 1 to 300 or one event in the prior year. What we're also learning more about is risk. And we do know that inhaled corticosteroids will increase the subject's risk for pneumonia. I would say most of the studies do not show much additional benefit for patients with eosinophils less than 100. And then the other thing to think about is sometimes we do have mycobacterial infections in patients with COPD that sometimes may also need to be part of that treatment decision. But, I think it is interesting that we are starting, in particular, Fernando, starting to think much more carefully about this, not just the initiation, but also sometimes withdrawal.
So, MeiLan, let me ask you one quick question on this section before we go to our last section, which is, we've again talked about the pandemic and bad COVID. Since there's been more hesitance for patients to come in and we're doing a lot more video, what has been your approach to training individuals in the complexity of all of those delivery devices that you highlighted earlier?
Yeah, no, it's a huge challenge. I have done everything from screen sharing on Zoom to showing patients what the devices look like, screen sharing videos of how to do things, having the nurses call and do the same, telling my patients go into the pharmacy and have the pharmacist show you how to use it. But I think that the good news is one great resource, to be honest, I think is the COPD Foundation. Has a lot of videos. They're also available in an app form for physicians, and they're sort of brand free and offer some great training tools for patients. But you're right, it's yet another pandemic challenge.
Yeah, no, but I agree with you. I love the COPD Foundation website. The last section that I'd like to take you guys through are sort of a further expansion of the thoughts regarding how to individualize therapy, how to target morbidity and mortality. So we've talked about how the bronchodilators can improve breathlessness. That was that EMAX study that MeiLan discussed so well. You have to understand and you have to use all of the therapeutic approaches at your disposal. So this particular slide from Peter Lindenauer is actually one that I don't want you to forget, and that is the importance of pulmonary rehab. So this is an examination over the course of about a year after a COPD hospitalization. What occurs if you have a patient involved in a pulmonary rehab program within 90 days or after 90 days, or if not using it at all. And it's a pretty significant difference. So this concept of pulmonary rehab and pulmonary rehab around an exacerbation event is one that I don't want you all to forget. I mean, it is a very relevant intervention that has many benefits. This is one of them. But I did want to briefly talk about some of the more recent data regarding the potential of triple inhaled combinations. MeiLan talked about the dual bronchodilators, the potential of inhaled steroids, the good and the potential bad. And so I think we've gotten a little bit better sense now of this inhaled steroid component, particularly inhaled steroids added to dual bronchodilation, so that triple, a long-acting beta agonist, antimuscarinic, and the inhaled steroid. And that's most recently based on two large studies that we've been involved in, the ETHOS study and the IMPACT study. This is a very busy slide with a lot of numbers. I don't want you to pay attention to every one of those. What I do want you to see is that in both ETHOS and IMPACT, if you look at that third row of data, the lung function of these individuals is around the mid 40% range. And then down below, the last two, you'll see that the majority of these individuals had exacerbations and multiple exacerbations. And in fact, about a quarter of the patients in these studies had actually been hospitalized in the prior year. So what ETHOS and IMPACT did was provide us a sense of how triple inhaler versus the LABA-LAMA versus an ICS LABA were compared in the same device in a very severe patient population with a lot of exacerbation risk. And that patient population is particularly relevant because if you look at the primary endpoints of both studies, which was an exacerbation reduction, it was very clear that the triple agents, whether it was ETHOS on the left, IMPACT on the right, the triple just did better. It had a lower overall exacerbation rate in this population, moderate to severe. It was very similar in both studies in terms of the level of benefit. You can look down below at the hazard ratios or the risk ratios, and it's just amazing the level of concordance between two separate studies. in a very severe population. Both of these studies were also quite influential to our thinking because for the first time, there were definitive data in two large studies that in a very severe patient population, there was a mortality benefit of all-cause mortality. On the left-hand side is ETHOS, and you see the bottom is that triple. On the right-hand side is IMPACT. The bottom is the steroid-containing preparations. And in this population of individuals, it was clearly evident that steroids had a mortality benefit. So I think that has influenced our thinking now in terms of how we would potentially present that to our patients. And so if you look at some of the comments that have been made, MeiLan, by a series of authors regarding this, is to highlight that even though these studies were not primary mortality studies, there was a lot of concordance between these. And it does give us a sense that this is something that we should consider in our decision making. So MeiLan, you've been involved in these studies, so you're quite familiar with this. How have you operationalized these, and how do you recommend your primary care clinician colleagues to utilize these mortality data in their patients?
Well, I think that to me, what this data suggests is that when you treat patients appropriately and you're reducing exacerbations, in particular hospitalized exacerbations, you're saving lives.
Yeah.
I am not going out and saying, well, every patient needs to be on triple therapy from the second that I, meet them. I don't think that's, what the data is saying. We have to look at the patients that were included in those clinical trials. And in general, FEV1s were sort of in the 45% predicted range. These were high-risk individuals. CAT scores around 20. They had all had around 2 exacerbations on average in the prior year. So when you have a sick patient that is appropriately treated, they'll do better, and we will save lives. So I think the message, though, and the message that gets out there is that treatment matters. It matters whether we do the right thing. If we think about patients appropriately and get them on the right therapy, because we can save lives if we do the right thing.
Yeah, so that leads us to, that's a perfect way to summarize, MeiLan. I think what we've tried to get across to you is that COPD prevalence in the US is increasing, unfortunately. There are lots of unmet needs, particularly around diagnosis and the appropriate use of spirometry. Clinical impression alone is probably not enough, and particularly now that there's a lot more granularity in that last comment MeiLan said, which is treatment works. Both, whether it's the GOLD therapeutic strategy or the ATS evidence-based recommendations, there's now a better framework for the individualization of pharmacotherapeutic and non-pharmacotherapeutic approaches for our patients, including bronchodilators, inhaled steroids, additional non-pharmacological approaches like pulmonary rehab. All of those work, and an appropriate way to encourage diagnosis and assessment of our patients does have practical ramifications for patients and their caregivers. Well, I hope you all enjoyed the recorded presentations. MeiLan, I hope we're not going to duplicate some of our comments that we made a couple of weeks ago. Remember, you can post or tweet questions in the comments, and they pop up on our screen here, so we can do our best to get to some of those. There are already a couple of questions there, MeiLan, that I'm going to just start off by posing. The first is you had, both of us had described the GOLD therapeutic strategy document and the modifications that were made with regards to double and triple and inhaled steroids and so on. In the dyspnea algorithm, there still is steroids that are in there for modification of the sensation of breathlessness. What is your sense of the strength of the data suggesting that the addition of steroid therapy, inhaled steroids, to bronchodilators has an effect on health status and dyspnea?
So I think that's a good question. So if you look at the GOLD algorithm for treating dyspnea, we see that bronchodilators is the first thing, and moving up to dual bronchodilators is the next thing. But certainly there is this section on there that says that inhaled corticosteroids can be considered, and what's the evidence for that? Well, you get your biggest sort of bang for the buck with respect to bronchodilation from the bronchodilators, but there is some evidence that inhaled corticosteroids do improve lung function and probably do provide some modest benefit. Sorry, I've got lighting issues here. For those of you who we've had some technical challenges with this program, so I apologize. There definitely is some benefit for inhaled corticosteroids, I think, in individual patients. So my general thought is I try bronchodilators first, but I'm not against trying inhaled corticosteroids if I feel like a patient needs more needs even more dyspnea benefit. I think it's definitely worth a try. Is that how you approach it, Fernando? Or
Yeah, I mean, I think you're right. I think I think that's the way most clinicians have operationalized some of those recommendations. One of the other things that was evident to me from just watching this video that you and I made, MeiLan, one of the things that we actually didn't talk much about was oxygen therapy. And given the data from the LOT and the data from the recent Canadian trial of nocturnal oxygen, have you altered the way you use oxygen therapy in COPD patients?
I think that's also another really great question. I don't know how many of our listeners have seen the data from the long-term oxygen treatment trial. So to remind everyone, our original data on why we use oxygen, how we use oxygen comes from two trials, the NOT and the MRC trial, where we show that we save lives when we use oxygen in patients with pretty severe hypoxemia. But the question that the LOT study addressed was in patients with more mild oxygen impairments. So, kind of 88 to 93 at rest. They may dip that down a little bit more with ambulation. Did those patients benefit? And they really did not see either a hospitalization or a mortality benefit. They also did not see a huge benefit with respect to symptoms or quality of life. Now, that doesn't mean that CMS has changed their coverage policy any, and it also doesn't mean that I withhold oxygen from patients. I think individual patients probably do benefit those with sort of that more mild to moderate hypoxemia, but I'm not perhaps as militant about it. But I do strongly encourage my patients with more severe hypoxemia to use oxygen.
Yeah, I mean, I think that the comment that you made has been my take, having been involved at least in the lot, and that is I'm much less militant about the exertional desaturation component, and I think that that's probably about the best summary that we can make of that. MeiLan, you are part of the Gold Science Committee, and you've seen a whole series of email traffics in the last week regarding vaccination and any changes in vaccination recommendations. I realize that we haven't made any additional recommendations. We're going to review all of this again in the fall at the ERS meeting. What is your current sense, particularly in the setting of the COVID pandemic and the changes in influenza prevalence last year with the pandemic, with regards to what you recommend for vaccination strategy for COPD patients, and is it age dependent?
Well, I think we can all agree everyone should have influenza every year. I know we didn't have a lot this year, but I don't think we're all going to remain masked forever. So my anticipation is that influenza is definitely going to come back. We now know that in all likelihood, COVID will probably be an annual vaccine or some kind of vaccine where boosters and additional for variants is probably going to meet it. Another question though is pneumonia vaccination, and people do vary a little bit there, but for any of my patients who have chronic respiratory conditions, I do recommend pneumonia vaccination. I think there is also some question about whether to revaccinate. The CDC guidelines have suggested a second redose after the age of 65, and so I will, if it's been 10 years apart, and that's I think the general guidance that I tend to follow for pneumonia vaccines. But there's always individual cases. As you know, Fernando, we did a study, and I don't think there's any harm with additional pneumonia vaccines. But I think it's also important to not forget some of the other other things like herpes zoster, for instance, and just some of the other all of the age appropriate vaccines I think are appropriate for COPD patients.
Yeah, I mean, I think as you saw some of that email traffic back and forth sharing some of the CDC guidelines, I had sort of forgotten the complexity of the guideline recommendations, and we overlooked things like the zoster vaccine, and so I'm glad you mentioned that as well. We've only got 1 minute, so unfortunately, MeiLan, as the program moderator, I take the advantage of being able to ask the questions, and so I always put you in the spot like 5 times in a row here. The last question that I'll pose to you is something that I know we talked about in the recorded presentation, but what is your sense regarding the strength of the data for tele or remote rehabilitation, particularly in the pandemic era?
I think we're starting to get really good data that telerehab can be effective. But we've got we've got multiple studies, of varying quality all over the country, all over the world, really. And I think what we really need is some consensus on what the key elements are so that it can be duplicated in multiple practice settings under multiple, coverage settings. And we just need to kind of agree on the key elements and how to do it. Because right now, I think not all patients are really able to access it outside of a clinical trial environment or, certain specialized settings. So I really like us to figure out how we can make that a more consistent and available for all patients effort.
Is there a reimbursement issue with telerehabilitation right now, as far as you know?
I have to admit, I don't fully know the answer to that question. It's a good question. We haven't actually gotten a program here off the ground yet. It's been. Are you doing anything at Cornell right now, Fernando?
No. Same problems. I mean, there's a group here that we work with that has been doing a tele-rehab, but I'm going to have to send them a little email, ask them if they've had any issues with particularly CMS reimbursement, because I don't know the answer to that either.
And everything with virtual is probably subject to change too. So even
Yeah.
the virtual visit. So that's one of the challenges I think all the health systems are worried about too.
Yeah. I'll turn it back over to you for the end here, MeiLan.
Okay. All right. Well, thank you. Want to just thank everyone, for joining us for this presentation today. It looks like our time is up. To our audience, thank you very much. Please make sure to claim your CME credits by completing the post-test and evaluation form at integrityce.com/COPD post-test 1. This link can also be found in the video description. Thank you so much and have a wonderful evening.
Bye, guys.